This is where I think rehab gets really sideways, is they want to add things to somebody's life to solve a current problem. But then you just have to keep adding that thing to solve the problem over and over again. The same things that rehab the problem at the root cause are the same things that help you maintain and prevent and perform. There's no separation. You need to know where your limitations are. You need to know, do your ankles move enough? Yes or no? Do your hips move enough? Yes or no? Do your shoulders move enough? Yes or no? And if they don't, then you need strategies to improve those things so that they don't turn into an active problem.
Hey everyone, Derek Hines here. Welcome to the podcast where I'll share with you the patterns, insights, research, and technologies that we use in my own pain and performance practice to help people improve their health, speed their healing, and increase their longevity. Thanks for listening. I hope you enjoy it. Dr. Chad Allen, welcome to the Pain and Performance Podcast, my man.
Awesome. It's great to be here. Appreciate you having me on.
So we're gonna dive in. So if I am, mid-40s, low back pain, somebody tells me you need to go see Dr. Chad Allen. I present to your office. What do you think is the most likely cause of that? Why am I showing up with low back pain to see you?
That's a big question straight out of the gate. At first, I think maybe a little context. Like in the past 7 years, probably 95% of our clients have already tried and failed therapy and chiropractics, meds, injections. A handful of them had already tried and failed surgery. And so, we worked with that 40 to 55-year-old person like you're talking about, and they had already kind of been through the ringer. And it's important to know that because most people are not doing anything. They're trying to solve their low back pain, but they're getting a lot of treatments for their symptoms, and they're getting a lot of treatments for their diagnosis, which seems correct, but we tell this to all our clients. You can't correctly treat an incorrect diagnosis, and you can't completely treat an incomplete diagnosis. And that's what we've seen over and over and over and over is incorrect and incomplete. And so when you say most likely cause, that's kind of loaded because most people want that to be, this is the cause and that equals this solution.
Yeah.
And that's just not the way it is.
And some of that probably comes from like when we initially started the kind of scientific method in healthcare, it was like, I think the thought at the time was probably we're going to be able to find the one thing that causes this type of health problem. And in some certainly in some like chemistry problems, you have this certain type of viral or bacterial infection, and we know this thing fixes it. Yep. And we try and take that concept and then we try and bring it over here into functional pain treatment. And you're like,
yeah,
that's tough.
You're exactly right. A lot of medicine is A equals 1. This infection equals this treatment at this dose to create this response. And while, on the functional side, there is dose response for sure, it's 1A plus 2B equals 3C. You know what I mean? And just when you go out in the marketplace, people are still only looking at one variable, and you really need to zoom out and take a look at everything. And so we made a great habit of doing that. When I pulled myself out of the insurance-based markets and started just working with people who traded money for the result they wanted, we worked one-on-one. I just started checking every joint over and over and over again and really zooming out, looking at the whole body, and then figuring out, okay, what do we need to zoom in on actually? Yeah. And it's not just one thing ever.
Right.
There's always several things that need to be looked at. And if we're going to create kind of a generality for people, these are the two generalities that we have. Pain is not a medical problem. It's a movement problem. And if movement is the problem, movement can't be the medicine. Because the big saying is movement is medicine, movement is medicine. Movement is a lot of things, but it's not medicine. Medicine modulates, right? Medicine changes chemistry. Medicine changes, it's A equals 1. Movement in and of itself creates pain just as much as you can use it to modulate pain. And this is most therapy. They use movement to modulate pain rather than correcting movement to change the root cause of why that pain exists. And so it brings us to our second. Adding movement won't change your problem. Changing the way you move will change the way you feel. If you don't change the way you're moving, you will not change the way you feel.
I got you.
And
So
to
that's
do
what you
that,
mean
you
by
gotta look at a
movement's
lot of
not
things.
medicine. It's not that like movement can't be helpful. It's that don't just move more and expect that to fix the problem.
Yeah. Also, don't expect. I have a huge beef with therapeutic exercise. It's like, and dude, I got lots of soapboxes, but therapeutic exercise, it's like, okay, do this movement and it will modulate your pain. There will be a dose response for pain relief there. But if you don't change the underlying mechanics of how motion happens, then movement is not going to be the right thing. Moving more is never wrong. There's no bad movements. There's only bad movers. And so what you have to do is you got to zoom out and look at their movement pattern, and then just understand that whether the pain is in the back or the shoulder or the knee or the foot, the pattern has to change. The foot doesn't have to change. The back doesn't have to change. The pattern has to change. And to change a pattern, you have to look at all the joints.
Yeah.
Even just looking at the simple act of walking, all your joints are in motion.
Yeah, let's go to that. So our low back pain, what would you be looking at? What would that look like? Like, take us through. They walk in the clinic. I assume you're staring very hard at them while they're walking, and they're like, what's going on? But just take us through what that would look like and how people can kind of understand that. Because most people have probably went into their doctor, hey, my back hurts. They touch, they lay them down, they do a straight leg raise. Does that hurt? No. Flip over, palp. It's right there. Okay, let me send you somewhere, low back pain, and get you in. So let kind of work us through the workup of, you've got back pain. Let me peel all these layers back to see what pattern is causing some of this.
Sure. There's only 3 patterns we look at. The squat pattern, the hinge pattern, and the overhead press. These are real life patterns, right? Pretty much every movement that happens in real life is some variation of one of those 3. And so those are the 3 primary patterns we look at. But when somebody walks through the door, we don't start with the pattern. We start with the joints. Every joint should have a certain amount of motion. And if it doesn't have that amount of motion, we anticipate compensation. And especially if it's not just stiff, but it's also asymmetric. Asymmetries are much harder on the body in terms of compensation than just a limitation in total motion. And so we start at the ankles and we check 2 things there. One, pelvis symmetry. And this has been one of our kind of most mind-boggling findings in the past 4 or 5 years, is really 100% of people with pain, not back pain, any pain, have a pelvis asymmetry, which has a lot of names. Sacroiliac joint dysfunction, your hips are out of alignment, leg length discrepancy. It goes by many names. It's all describing an asymmetry in the pelvis. 100% of people we've seen in the last 5 years, we had that. Number 2, at the ankles, we're looking for dorsiflexion. None of the other motions really matter in terms of if you're going to change somebody's movement pattern. And so then we check pelvis, we check ankles, we check knees for flexion, extension, and internal rotation. We check hip, internal, external, and extension. We check shoulder, overhead, front rack, which is this one, for maybe people who aren't totally exposed to like Olympic weightlifting or front squats or stuff like that. Internal and external rotation as well, like the normal. Mm-hmm. We don't check the neck unless it's the problem. Most people's necks are fine unless they have pain there, in which case the pain is never where the problem is anyway. So we check the big movers that are going to change the patterns. We only start looking for more nuanced limitations when there's pain present and an obvious limitation there. But that's what we look at. We say, hey, look, Your ankle should move 15 degrees when you're laying on the table and you have 0. Okay. And so we're just walking people through how do they compare to the target. And then when we take them out and look at their actual pattern, we can say, hey, you remember how you had this in the ankle and this in the hip and this in the shoulder? That's what's driving this pattern you have. And so if we're going to change that, we have to change this.
Yeah.
Over here. And that's our evaluation. We don't do special tests. We don't get out our goniometer. You know what I mean? It's a yes or a no. You either have what you need or you don't. And we're just going to help you chip away at getting there.
Yeah, I love this. If we're walking through the up and downstream effects of let's start with pelvic asymmetry, and go through some of that stuff. If we are going through, somebody has a left pelvic asymmetry, so they've got more compression on the left side. What's the up and downstream effects of that? What's happening in the body whenever that happens?
Yeah. First thing I think that's really important to understand, the pelvis is a circle and it has no sides. And asymmetries in the pelvis don't ever happen on just one half of it. So it's pretty rare to see something outside of this. It does happen, but man, it's so rare. We don't even think about it unless somebody forces us to, because they're not making progress. 99 times out of 100, the right half of the pelvis is anteriorly rotated and the left half of the pelvis is posteriorly rotated. And there are things that match that people will talk about, like my quad on my left side always feels tight. Or like when people get down into flexion in the hip, they're pinchy on the right. Like it gets compressed in the hip early and it pinches. And that's because of the default joint position has created additional tension on the front and the left and additional compression on the front and the right. So we're never looking at left versus right. There's always something to correct on both.
Two sides of the same seesaw, right?
Yeah. I mean, it's give and take. But what happens is, this is a great question that you ask. What are the effects of that? Because you would think the effects of that might just be right there in the low back. But about 3 years ago, I had somebody come in and so you back up far enough, I would only check the pelvis for somebody with low back pain. Yeah. Then fast forward and I start checking everything and I start seeing, man, this problem is there all the time, whether the back hurts or not. The shoulder hurts or the knee hurts, this problem is there. But then kind of the magic happened when somebody came in for low back pain and shoulder pain. And so just by the natural flow of my evaluation, I had just checked the shoulder and it was abnormal, like in a bad way. It was probably missing 30 to 40 degrees of flexion. Front rack was 0 degrees and there were limitations in external rotation. And so I was like, okay, well, hey, let's do this. We call it the keystone reset now. We can talk about that later if you want, but let's correct the pelvis symmetry first. And so I did that. It takes like 60 seconds. It's not hard to do. And then I went back to the shoulder just to start working on their restriction there. And when I went back to the shoulder, it was normal. I was like, oh boy. So I thought it was a fluke. So I just started testing that on everybody. And after 10 people, we saw the same thing happen over and over and over and over. And after 50, I figured out, man, I better figure out why that happens. And so now when we look at the upstream and downstream effects, if you start looking into some direct connections like the lats, the lats attach to, let's just say, the left shoulder. They attach to the left shoulder, to the arm itself. They attach to the shoulder blade. They attach to the spine. And it attaches to the same side of the pelvis and through what's called the thoracodorsal fascia to the opposite side of the pelvis. That's very, very direct. And so that was an easy one. Like, okay, well, when we change this position, we change either the resting, length tension relationship of that thing. But then we really started digging into like anatomy trains, which I'm sure you're familiar with, and all the different like planes of fascia that exist in the body. And we started seeing much more deeper connections through the fascial system.
Explain anatomy trains real quick. We've talked about it a lot on here, but in letting the listener kind of be able to catch up with us a little bit.
Sure. So most people are aware of fascia, at least if they've heard of their plantar fascia. So that can give everybody kind of a baseline, like of yeah, fascia is real. We've been knowing about it in the foot forever. The plantar fascia is just the thickening of the superficial back line as it exists in the foot. So anatomy trains will define different lines in different areas, but essentially fascia is like a bodysuit. And anatomy trains is the deep dive into the bodysuit of fascia. There are different tracks, which they call them tracks, almost like a railroad, which I really like because we kind of reiterated some of their ideas. Because as we've seen how the pelvis changes the up and downstream effects without touching the fascia itself, I'm more to the tune of rather than the superficial backline starting here and going down, it starts at the pelvis and goes up and starts at the pelvis and goes down. Especially because we see the break in the line where the superficial back line is central and then it goes to the pelvis and it splits in two and goes down. So regardless of that, listeners just need to know, like, you are connected head to toe.
Yeah.
Like, so from a therapy perspective, we need to get rid of this like minimal scope of like, yeah, check one joint up and one joint down, or regional interdependency of, how do these things affect the things in close proximity, and really start understanding like, dude, you're connected from head to toe. We've seen some of this even with like, hey, roll the lacrosse ball on the foot to get rid of the headache.
Yeah. Yeah.
You know what I mean? So there's hacks out there we can start kind of
the superficial backline, just for those, if y'all Google it, if you're listening to this, don't do it if you're driving or something, but it'll show you how the fascia from the plantar fascia of the foot is connected in through the Achilles tendon, in through the calf, into the hamstring, into the pelvis, into the lower back, all the way up your back and into the neck. That's the picture you would see if y'all Google superficial backline. I had a friend of mine, I was out of town, and he's like, man, my back is just locked up. What do I need to do? I was like, look, I'll be back in a week. I need you to start like just loosen everything along that line. So get a lacrosse ball, get a foam roller, roll out your neck, your mid back, your low back, your hip, your hamstring, calf, and your foot. Start rolling out your foot. And so he's like, send me a message 2 days later. He's like, dude, I feel a whole lot better. Thank you. I was like, what'd you do? He was like, I didn't want to lay on the ground. So I started rolling out my foot, and then I took the ball and I put it on like my coffee table, and I rolled out my calf and my hamstring. And he was like, man, my back felt better. So he was like, well, I'm not gonna lay on the ground. So he was like, it was not, he was lazy. He was just like, getting on and off the ground right now is gonna be painful. So he was like, for the last 2 days, like 3-4 times a day, I've been rolling out my foot, rolling out my calf, my hamstring. Kind of that's resolved 80-90% of the pain. I mean, this is 6-7 years ago.
Yeah.
And so I was like, okay, like this has to be something that is more connected than people are talking about. So sure. That's where this relates to y'all. If you're listening to this, it's very real connections in the body that is not like, oh, my foot relates to my back in the little like nursery school rhyme. Like, this is real connections in the body. Anyway.
But what's interesting about fascia is it's not just up and down, it's inside to out. So we actually see on deeper levels, fascia exists right under the skin, and that's like the bodysuit. But the matrix of the fascia then goes in and it wraps the entire muscle belly. And then it goes and it wraps each muscle fiber inside the muscle belly. And then it gets and it wraps around the bone. And that's what's formally called the periosteum. It's the most outer layer of the bone, and it's really just fascial tissue.
We had, complete aside, but I had Julia Blackwell, who's a fascia expert, brilliant fascial therapist, who came on, and we were talking about a lot of the research around fascia. And one of the things that she brought up is like a lot of the studies into fascial tension and how neurodynamic fascia is. We think of fascia as this like hard, dead, tight system that's just like this hard covering. And we're like, that's not what it is. It's dynamic and it's alive. And if you put pressure into it, it'll send signals throughout the whole fascial train or tract, if you want to call it that. and change the tension throughout that whole track. So really, really interesting in how much you can change that fascia through there with, palpation or rolling out or any of those kind of things. So
I lost you, man.
very interesting
I don't
how
know if
much
you can
that
hear
does
me.
change. Okay. Yeah, just how dynamic the fascia is, like how much it's actually taking signals. And when those
Hmm.
signals change, the whole fascia tension changes.
Yeah. And I think something that's really, really interesting is as they've studied it more, they've started to recognize how highly innervated it is. And I think, we're getting all these diagnoses like fibromyalgia, just these widespread pain conditions. And I don't want to get out in the weeds of that. I think the body craves motion. I think people need to take better care of themselves. I think people need to eat foods that don't, squirt lighter fluid on all the little fires that are going on in their body. But really, if you think about the fascia and how it integrates into the body, and if it starts moving, imagine trying to push two layers of Velcro and trying to shear them off of each other. Just the amount of tension that would create, the amount of disruption that it creates, and I don't have anything to back that up, but just conceptually, to me, it makes sense because we know fascia has directionality. And if your fascia is crawling up in some direction, then you're creating a ton of internal stress on your body. And I would love to study that more. That's not really where my career path is going, but trying to help people make sense out of why they feel the way they feel is a
Yeah.
huge part of helping them start taking action steps on making moves in the right direction.
Yeah, we had a woman who came in yesterday who has gotten tons of relief from like dry needling and
Mhm.
deep pressure stuff, and we start looking, and her pain relief is there, but nothing has lasted. Like
Sure.
she's gotten better, and she's like, "Look, I'm 50% better than I was." But we start looking at full motions from shoulder, neck, low back, and you can see when she's moving how restricted the fascial tension is. Because when you get into the muscles, you're like, look, they've released the trigger points,
Hmm.
but that's not where all of our motion restriction comes from. It can be. So for her, getting in and doing some of these like really deep kind of like fascial gliding, active release, all of that stuff, some deep like cupping with movement stuff. She gets up and she's like, I've never felt that I could move like this without inside my body something just yanking on it and
Yeah.
increasing the tension there.
Yeah. And it's been our experience. I'm never going to tell you anything that's like, hey, look, this is it. This is the only way. You know what I mean? Because I don't know. But I can tell you what has worked really well for me across, I don't know, 10,000 people at this point. And it's been my experience that when that is the case, there is a joint restriction nearby, probably. Sometimes it's further away. We see the ankle change patterns in the shoulder in pretty dramatic fashion, depending on, like for an overhead squat. Right? I learned more about how the body is interconnected working with CrossFit athletes than doing anything because we see the person come in with a trashed shoulder joint and it moves normal. It's like, okay, well, what's the problem? And we look at their shoulder press and it's normal. And then we look at their overhead squat and we see, well, your ankle's a brick. And so their torso angle then gets really low and their shoulders end up in this really wretched position. And so, we've learned a lot about the connectedness of the body through movement, not just through like the actual connections on the inside. But what we've always seen is that if we change the joint first, trigger points fall off the map, fascial tension falls off the map, movement is restored at a much faster pace. And so, like, if there's a true joint restriction, our first play is always create space in that joint so it has the opportunity to move normally. And this is what I hate this more than anything about therapy is a lot of people go by the research, good for them, but almost all of it's inconclusive and there's always a camp on both sides. You know what I mean? It's like there's a camp that's like manual therapy doesn't work. It's like, yeah, nothing works by itself. You know what I mean? And then there's a camp that's like, no, manual therapy does work. And we have seen it work, but we don't use it to change pain, and we don't use it to change mobility. We use it to change movement. If you don't use it, you lose it. You can do all the manual therapy in the world, and if you never have somebody tap into that, it's just going to disappear like it did the first time. But we've seen this over and over where somebody can come in and they're pretty loaded up with trigger points, and if we just make their joint move normally, whatever one's not working, then trigger points just go away.
You think that's more of the trigger points are the body trying to protect that joint, and as you remove that need for protection, the nervous system kind of feels safe and down regulates the trigger points. What's your thoughts on why that's happening?
Trigger points are a phenomenon secondary to overload, right? So you can develop trigger points just through good training. You know what I mean? You're overloading the muscle frequently and consistently, your body will develop trigger points. Most of them are latent. They're not active. The difference is you press into it and it hurts versus an active one. It's producing pain actively and creating problems. And so as we see it, when the joint can't move to its full capacity, your muscular system is what is trying to overcome that joint limitation. And so it just adds more overload to the system.
Gotcha.
And when you remove the stress from movement, you allow the muscles to function more optimally, then you start to see some of these active trigger points start to fizzle out. Now we do dry needling, and it's a phenomenal tool. Yeah. Phenomenal. It's a total game changer in pain relief, especially once we started playing the trigger point game of not needling where it hurts, but needling to restore joint position and needling the referral pattern.
Yeah.
Not the painful area. Dude, I hadn't needled where something hurts in forever. I'm always needling somewhere and like, dude, why are you doing that? It's like, just trust me.
Just watch. All right, now move that again. So we talked about how, the diagnosis is rarely the correct diagnosis. What does your diagnosis look like when somebody comes in? Like, what's it sound like to y'all?
Yeah. And I'll at least say, a diagnosis of patellar tendonitis might be correct.
Yeah.
But it's severely incomplete.
Correct.
Most diagnosis in like musculoskeletal stuff is just a relabeling of your pain. Hey doc, my knee hurts. It's like right here in my patellar tendon. I think you have patellar tendonitis. They just relabeled what you said with a fancier term. You know what I mean? Most people can Google. If you can Google what your diagnosis is, it's not the right one. Okay? It's just not. But the point is, as soon as you create a diagnosis, that's designed to control the treatment pathway to follow. So if your diagnosis is local and specific and passive, your treatments are going to be local and specific and passive. So we don't create a medical diagnosis or a therapy diagnosis. We create a functional diagnosis, which for the layman and the listener is you move like a turd. Like your squat does not look like a squat should look like. Your deadlift does not look like a deadlift should look like. And now, we see a lot of people who, by the world standard would look at their squat and be like, that looks pretty good. But there are these little nuances of movement that can totally change the way somebody feels. And the only reason we know that is because we've just had enough time and repetition on seeing people move like this and it hurt and move like this and it doesn't. I'm not even going to say, because I know there's some other clinician out there who's going to get their panties in a bunch. We're not saying this movement is right, but we are saying it doesn't hurt, which we think is more right than this, which does. Yes. And our clients would agree. It's like, well, I don't care if it's right. If I can do it like that and never get hurt again, good for me and good for you.
Yeah.
So it's still, again, coming from the place of just what we've seen and been successful with. You could get lost in like, hip socket depth and, you can't squat that far because your sockets are too deep. It's like, okay, if you want to go get an image on that, go for it. But really, if you're using that to justify not putting the work in to make sure your movement is the best it can be, then why are we even having the conversation anyway? But we're gonna say, look, like, there's nothing wrong with your body. There's something wrong with the way you're moving, and it's just creating that stress right there. Maybe you do have a disc bulge. So do, a million other people that don't have pain. You just can't take a lot of that stuff at face value when it comes to movement-based pain. And so we're just going to tell people, look, here's the deal. We can't know your pain is due to this anatomical thing until we clear the ankles, the hips, and the shoulders, and your movement looks like it should.
Yeah.
And that's when we're going to start maybe looking down a different rabbit hole.
So when you're doing this, I know I'm pressing you on like what a diagnosis would look like. Is it like, okay, left shoulder restriction included with, right pelvic asymmetry, anterior left posterior, down to left ankle dorsiflexion, all of that functional pattern creating increased stress across blank, whatever.
Yeah. I mean, you could say that. We just don't do it. Like, we don't have to, you know what I mean? We don't have insurance breathing down our necks to give them a diagnosis code or put somebody in this little box. And like, truthfully, people don't care.
Yeah.
If we just ask them, they'll start going on and on about their diagnosis and all the places they've been and things they've tried and wondering why they're not getting anywhere. And I just ask them, hey, listen, if you wake up tomorrow and you could do anything you wanted to do and you didn't hurt when you did it, would you care what your diagnosis is? Would you care what your image report said? And there's no. Okay, well, just forget it then. Because we're not going to like try to confine this thing to a single diagnosis. Because the diagnosis, if we're going to be like real about it, is you're making a lot of lifestyle choices that have led you to this moment. That's it. You sit too much and don't have a strategy to break your body out of that position. And then when you go try to attempt, 60 minutes of exercise, you got problems. People spend 23 hours a day in fetal position and then attempt 60 minutes of aggressive movement in not fetal position and wonder why their body hurts.
Yeah.
And I mean, dude, I wish I could tell you, here's our diagnosis. We're going to call out, this is what things should move like, and this is what you move like.
Yeah. Yeah.
So your diagnosis is you're here and not here.
Yeah.
It's just hard. It's hard to like.
Well, that's what I want people to kind of understand is like when you're looking at a functional diagnosis, this is one of the things that I see about back pain that doesn't get resolved with injections or surgeries is that there's an internal movement pattern that is increasing stress across the disc. We can go in and put hardware in, and we can go in and do surgery and trim up damage to the disc, and we can do injections and all that stuff. But if we don't remove that pattern that was increasing compression across that disc asymmetrically, causing one side to get a lot more stress, if we don't go in and correct that underlying problem, you can do surgery, you can do injections, all that stuff, but you didn't remove the problem.
Yep.
And so, of course, there's going to be another thing that happens later on in life, whether that's another, the segment above broke down. Yes, the problem's still there. The underlying issue that started this whole thing didn't get addressed by your surgery or any of the other stuff. So if we don't go back and start fixing those things. So that's why I think the functional diagnosis thing is so important for people to get a grasp around. Yes, we can describe, you have a disc herniation. Same thing. All I'm doing is taking what you said, low back pain. Maybe I have an image and I'm just putting, here's where the symptom is, but I'm not telling you what the actual problem is.
Yes. And that's a critical distinction we make is source of pain and root cause of pain, not the same. Disc herniation is a symptom. And people view that as the problem. Mm-hmm. And so they treat what they view as the problem to get rid of the symptom of pain, but they never got rid of the symptom of why did the herniation happen in the first place. And that's the difference that people really need to understand is, okay, your meniscus tore. Why? That's the root cause. Your disc herniated. Why? That's the root cause. You tore your rotator cuff. Why? That's the root cause. And the first place people are going to go is like, well, I'm just getting old. It's just wear and tear. It's just overuse. But you got to understand, like, there are feats of incredible human performance, incredible use of. Look at ultra marathon runners running hundreds of miles at a time, and they're fine. You cannot overuse the body; it's impossible. But you can misuse the heck out of it.
Yeah.
And that's root cause. That's root cause of any structural damage you create in your body is because you have misused it for a long time.
A lot of this is tough, right? Like it's hard for you to get to the bottom of this stuff. I think it takes time, it takes attention, it takes extra energy to kind of look through all of this. It's not so much as like, kind of memorizing special tests like you were talking about. I heard a comedian talk about, he was like, you're getting old when your doctor just doesn't care anymore. You're like, hey, my ankle hurts. I'm like, yeah, that happens. And he's got a whole bit on it. Like,
As Nate Bargatze, we just went and watched him a
like,
couple months
here's
ago.
your ankle. It's worn out, man. Well, what's that mean? Yeah, it's just worn out. And it's funny. And unfortunately, I think it's also true a lot of times where it's like, it does take energy to look at these things. And I don't want to say that we're lazy in healthcare, but the system doesn't seem set up. Why do you think that this isn't more commonplace in terms of pain treatment and healing?
Well, I got a lot of thoughts on that, so we'll try to keep them confined here. But when you look at the medical system as a whole, the patient's not the client. The client is the insurance. And providers have to do what the insurance wants to get paid. And that minimizes the patient experience. So, like in therapy especially, what that's created, because reimbursements are going down every year, is that therapy centers have to see more patients to keep the doors open. A lot of people think it's corporate greed and they're money hungry. They're not. Dude, if they don't see 3 patients an hour, they don't exist next year. And it's just a problem of the downstream effects of what's going on in the insurance-based markets and these big monopolies in healthcare. But I think the bigger problem that creates is it removes the ability for most clinicians to like innovate and think on their feet and think critically beyond what they can just get done in this 15 minutes they're going to get with that person, because that's it. And then they're going to go work with the tech and they're going to get some arbitrary sets and reps of basic therapeutic exercise. And we see people graduate as entry level doctors of physical therapy, and then they go into this clinical environment, and within 12 months they look just like everybody else. They're doing the same types of exercises, the same sets and reps, the same types of manual therapy as anybody they're surrounded by. And we've got 30-year veterans who are still entry-level PTs. So there's so many problems. Insurance creates some of it. Insurance creates a volume problem. Volume creates a quality problem and a time problem, and that creates an innovation and a think outside the box problem. And because of the way insurance has been designed, people have kind of been fear-mongered and conditioned into making decisions about their health based on, can I use my insurance, yes or no? And most people, there's a lot of people right now who are going to have surgery this year based on one piece of data. You know what that is?
What's that?
Their deductible's been met. Okay? They have not turned over every stone to solve their problem.
Yeah.
But their deductible's been met, which means they think their surgery is going to be free, and they forget about their, out-of-pocket max. And they're going to be really disgruntled next year when they're paying for therapy and still paying for their out-of-pocket max bill from the surgery. So, I just think man, the system has really set people up for failure because it's changed the way they make decisions. It's changed the way clinicians are able to operate and think on their feet and really pursue, man, how do we create change and results for people, because their box is too small. They got to get through the day, and they got to keep things as streamlined as possible because they're going to take 4 hours of documentation at home at night. And it just becomes difficult to really start to explore what is root cause. What can I do to move the needle for this person? Because what we're doing right now is not working. But like right now, you go to therapy, it's not working. I don't know. I think you should go see your specialist.
Yeah.
Dude, everything's a stepping stone to surgery. It's just so easy to get there now.
There's another thing that I wanted to ask you about. I was digging into, some of the talks and posts and stuff that you had done, and I was listening to I think it was Andrew Huberman when he had Stu McGill on, and he was talking about that interview, and he said after he put that out, he was like, I get hate for stuff that I put out all the time. He was like, that's just commonplace for me. He was like, but the amount of infighting and hate that I got from the PT world after I put that out was unlike anything I had ever seen. And I heard that. And look, I've talked about this. I'm like, we are a profession that maybe it's like the adolescence of us kind of trying to get into like being a doctoring profession and all this stuff. I don't quite know where it comes from, but I've heard that so many times from different doctors and different professions of they're like, man, y'all tear each other apart. They're like, we don't do any of that stuff. Where do you think some of that stuff comes from? Because you obviously think outside the box with a lot of this stuff, but and I've heard you talk about, hey, a lot of our people have failed, but I haven't heard a ton of you like kind of trashing other professionals, so to speak. Where do you think some of that's at in this world, and is there something that we can do about it as PTs?
Yeah, I think some of it probably comes from just, PTs are fighting for scraps. And I think there's a lot of layers to this. Like you go to school, you get loaded up with, six figures of debt. You come out and you realize, man, the median salary is not as much as I thought it was. You go to school when you're a kid, essentially. And you come out as an adult and you get a wife and a car and a couple of kids in a house and you realize, man, I just got my doctorate and this little thing's not going very far. So I think you can kind of load it up with that. And then you get them coming into the space. And by the time they're working for a year or two, they realize like, man, helping people like this is not what I thought it was going to be. Uh, it's a lot of work for a little pay and it's a lot of stress and it's a lot of high volume. You get a lot of burnout. And then I think kind of the straw that breaks the camel's back is when you really look at what a PT can do for people. There's no doubt there's value there. But then you start to look at chiros and you start to look at ATCs and you start to look at massage professionals and you start to look at strength and conditioning coaches. And all of these professions can get the same certifications. Like MDs and DOs, you can't go get the certifications they have. Anybody can go get a medical exercise certification. You know what I mean?
Yeah.
And so there's just become there's so much lack of separation between what PT is and could be because there's so many other professionals who say they do the same thing. Now, whether they can or not, it doesn't matter because perception is everything in the eye of the consumer. And, and when you go to therapy and you get a home exercise program that's basic, and you come back to the clinic and you do the same basic home exercise program, maybe they adjust sets and reps. And then they go to their trainer and they're like, hey, I think I need to go to PT. And they're like, you don't need to do that. I can do that for you. I can modify your exercises way down here for you. I can show you how to do stabilization exercises for your core or your hip. Or let's be honest, like strength coaches know way more about movement than most PTs. And so in a lot of ways, they're right.
Yeah.
And so I think there's this like push and pull of PTs fighting for scraps because they want to elevate their status up to the doctor. You know what I mean? And it's just really hard to do because we haven't had a lot of protection in the field of being clearly defined and separate from a lot of these other professionals.
Yeah.
They get paid the same. You know what I mean? A chiropractor runs the same diagnosis codes and therapy codes as a PT. A DO, like doctor of osteopathic medicine. They're a little more on the manipulative side and the holistic movement side. Same stuff. ATCs, same stuff. Medical exercise specialist. I mean, dude, you can look up TheraBand, external rotation, and clamshells on the internet. You know what I mean? So And then I think people wrestle with what they really want to be and realizing there's a gap between where they are and what they could be and what they want to be. And when people are arguing and hating on other professionals, what they're really saying is, I wish that was me. Like, why am I not doing something for myself to push this forwards? Why am I not thinking outside of the box and having an opinion? It's one thing to have your own opinion, and it's another thing to just argue with somebody else's.
Yeah.
There's so much wrapped up into that. It's annoying. You know what I mean?
Yeah. I said, you mentioned like not getting progress with somebody and, hey, just go back to the surgeon. Maybe you need an injection and stuff. And it's like, I would love to see more of like, hey, actually, this is a weird nerve thing. I'm not super proficient at this yet. I've heard that there's a PT down the street who does really good stuff with nerves. Go check him out. There may be some weird movement pattern that I don't know. There might be some compression around that. Why don't you go and get that looked at? That happens in every other healthcare sector, but it doesn't happen a whole lot in PT. Yeah. So let's do this. Doc. I'm gonna throw out a couple of things that we pulled from posts that you've made, and we can just kind of expand on them as we will. So one of the things we pulled out was like weakness doesn't cause pain.
Oh, good one. Yeah.
Carry that on for me.
Okay. Simple illustration. You got bodybuilders who can lift a truck, tremendous amounts of pain. You have 98-year-old grandmas, weaker than skim milk, who have zero pain. So you can't just attach pain to weakness. And when we're looking at functional patterns, a muscle in isolation doesn't mean anything. And we really drove this home when we started recognizing when we start with joints first, things that appear weak were actually just inhibited and not actually weak. And so a great example of this is, and anybody, like if you're a clinician, you can do this. You'll know what I'm saying when I say it, and then maybe we can back it down into something that's a little more easy to digest for the listener. But hip abduction test, sideline hip abduction, right? Hey, raise your leg up, hold it when I push down, and then it just flops. It's like, oh, we have a weak glute med. Of course, we should do clamshells and leg raises. But if you go test that like clamshell position, external rotation, and push, it's normal, almost always. So what's the discrepancy between the long lever position and the short when there's obviously a huge discrepancy there? And if you just go into the QL and just dig and work that thing over for 30 seconds and then retest the long lever position, 5 out of 5 by working the QL, because what appears weak is actually an inhibition of the overall stability of the pelvis, where the pelvis can't stay close to the rib cage. And so the hip is actually not changing position much. The whole pelvis is just dumping out in that position. So hit the QL, and now all of a sudden the strength comes back. If you can improve the strength in 30 seconds with pressure, it's not weakness, it's inhibition. Yeah. And strength is a long game, and strength is a fitness problem, not a medical problem. So, I mean, what are we doing? We got to be solving the real problem, not the fake problem. And if we want to attach pain to weakness, then you're telling somebody, hey, to get stronger, we really need a progressive overload progression, and your pain relief is on the other side of a 16-week progressive strength training program. Yeah. You know what I mean? But that's not the case, and it shouldn't be. Yeah. And so we always see inhibition rather than weakness. And this is especially true in like the active population. I always hated when I see a CrossFit athlete or an Olympic lifting athlete who would go to the PT down the street and they were like, yeah, they told me my glute med was weak. I'm like, how much do you squat? 450. It's like, bro, good news. Your glutes aren't weak. You're probably okay. And so we got to start diving a little deeper, but yeah. It's easy. Everybody wants the easy button. Oh, hey, if we just strengthen up that muscle, you're going to be fine. And then they're not. And then what?
Go to your specialist.
Yeah, if you don't have a pathway to work through, man, what's after this? Then referrals happen way too early in the process.
So this one resonated with me quite a bit. Just because it doesn't hurt doesn't mean it's normal.
Oh, that's a big one. Who said that? This really hits home when we start looking at all the joints and we start tying this together for people in the context of functional movement. And we like to think of this as like a movement screen, just like you do a biometric screen where, hey, I'm going to go get my blood work done and see what's going on under the hood. You don't do that because you've got the problem already. You do that to see, do you have indicators that could lead to the problem later down the road? You take your blood pressure to see, is it normal or is it not? And when it's not, you address that so it doesn't turn into a cardiac event. You know what I mean? These are the things that happen in medicine that don't get translated over in a really positive way to musculoskeletal stuff. And people's mindset is it's not working right when it hurts. That's my indication, but it's not. The indication is this has been probably one of the best things we ever did with our clients is educate them on what pain is, because nobody's doing it. And people think pain is just, well, it hurts and it means something's wrong. Pain is just it's a feedback loop. It's just telling you need to make some changes, and they're not specific to where the pain is. This is where we're like really trying to communicate with people. Why is the stress adding up in that area? And this is why you have to look at the things that don't hurt. Just because the ankle doesn't hurt doesn't mean you have normal dorsiflexion. Just because the hip doesn't hurt doesn't mean you have normal hip external rotation. I haven't seen anybody with, maybe one out of 700 that have normal dorsiflexion. It's just not common. You know what I mean? And especially when you start comparing to, like, look, you need to understand, like, if you're going to do these things in your daily life, they require this much mobility in these ways to do this without compensation and stress in your body. And if you just don't know that, then it's hard to understand. So there's so many things that we're trying to get out to people just to help them better understand what is pain, why do you have it, most importantly, how do you use that feedback loop to show you how to get away from the pain.
Yeah. What would be if somebody's listening to this and they're like, look, hey, I'm feeling pretty good. I don't have active pain right now, or they have some random active pains. What would be kind of some of the base set of activities that you see move the needle a lot for people?
Yeah, it's a really great question. One, you need to know where your limitations are. You need to know, do your ankles move enough? Yes or no. Do your hips move enough? Yes or no. Do your shoulders move enough? Yes or no. And if they don't, then you need strategies to improve those things so that they don't turn into an active problem. Because the same things, this is where I think rehab it gets really sideways, is they want to add things to somebody's life to solve a current problem. But then you just have to keep adding that thing to solve the problem over and over again. The same things that rehab the problem at the root cause are the same things that help you maintain and prevent and perform. There's no separation. So like the joint mobilizations we teach people how to do to themselves are the same thing that's going to restore their joint mobility so they can change their movement and change the way they feel. And those are the same successful actions they need to take to prep their body for movement every time they step into the gym or go play pickleball or whatever their thing is. And those are the same thing that's going to prevent things from coming back. They're also the same things where if you do have a little thing that happens, that will help you work right back out of them. And people just need to know, you know what I mean? If you're going to be active, you just need to know how your body's working. You get a brand new car, it's got all these features. It comes with an owner's manual. The human body is probably the most complex machine ever on the face of the planet in all of history. And you don't get anything to teach you how to use it. You know what
One
I
of
mean?
my patients had it, and it's such a great analogy. They were like, "Look, I brush my teeth every day, and yet I still need to go to the dentist twice a year to get like a professional deep cleaning." They were like, "Why in the world do we not tell people, hey, I know you move every day, you stretch every day, you should, you exercise, but a couple times a year, you need to go and get a professional physical cleaning and clean up those joints, find what's not working that's going to lead to a problem." Because they were like, I don't have a problem with my teeth yet, but if I let that plaque continue to build up, it's going to be an issue later. I don't
Sure.
have a problem with my ankle or my back today, but if I let those movement restrictions continue, it's going to lead to a problem down the road. I'm like,
Yep.
that's brilliant. Like,
Dude,
I don't know why we don't do that. Probably because of insurance.
well, yeah, that's one reason. And you got to think too. It's like people are lazy. You know what I mean? They don't know what they don't know. That's where all the magic is. Like the things you know are your greatest barriers to whatever you're trying to do next because you're comfortable. The things there are things that you know that you don't know that would be beneficial for you to learn, and you could see how those would move the needle for you. But it's the things that people don't even know that they don't know where all the magic is. And so it's just so important for guys like me and you to communicate. What are the things that people don't even know that they don't know? How do you test this stuff out? How do you do it? And it's impossible to be objective with yourself twice a year. Go put somebody's eyes on it to show you where are your blind spots, what are you not seeing, what's the missing link. It doesn't have to hurt to be a problem or create one sometime down the road. And yeah, I mean that would change the game for a lot of people.
Yeah. Yeah. You'd prevent a lot of stuff.
Yeah, it really would. It's a phenomenal idea. Somebody should push that.
So if somebody's listening to this, they're like, look, I'm checking this. My ankles are a little bit stiff. My hip, whenever I try and kind of, lay on my stomach and let my hips internally rotate, they don't seem to move. What's your favorite kind of home mobilizations for improving ankle dorsiflexion, hip mobility?
Well, number one, if you have pain current or you have had pain in the past, you need to check your pelvis symmetry first because you're probably whatever you're feeling is not the true version of what's going on. Because when we do pelvic symmetry, I've seen ankles flop from one side to the other. It looks like we need to do a lot of work on the right. We do the keystone reset. Oh, sorry, we actually need to do a lot of work on the left. And so you need to know your baseline. You need to get back to baseline to figure out what's true about your body and what's not. But then if we've got, some target areas that need to be worked, we have evergreen stuff. It's just the things like we don't need to be fancy. This series that we use will restore this joint position. There's no reason to break out of that. Just do it until you get normal. And then once you're normal, keep doing it.
Yeah.
But, I'm sure you're familiar with Kelly Starrett.
Mm-hmm.
Game changer in how we thought about home programs. We've taken and expanded on some of that, and we use what we call loosen, lengthen, load protocols. We loosen the joint first, lengthen the muscles around it, which could be a stretch or it could be a release, like a deep tissue release, because a lot of muscles you can't stretch. And then we follow that up with load, which is you need to put that in the context of functional movement and use it a bunch. And we're specific on our coaching in those moments. We're not just improving the motion to improve. We're improving the motion so your squat can go from looking like this to looking like this, because that's what's important. We want to rewrite that pattern in their brain. And so, Starrett's dorsiflexion mobilization with the band.
Yeah.
Phenomenal. Follow that up with a little bit of calf stretching or release the calf. In the context of the ankle, we really like to smash into the tib, because we see a lot of that anterior pinchy pain just because the tib is so stiff that when they go to dorsiflex, the anterior tib just bunches up into itself. So we need to get that thing to contract in the front, and then we're just going to squat or we'll work into some Ben Patrick stuff, knees over toes guy.
Mm-hmm.
to really start forcing that ankle down into a good position. Of course, if people have pain they're dealing with, we know how to modify things
Yeah.
like that. But at base level, it's, hey, change the joint and then use it. Use up that new motion. For the hip, same things. They're great band mobilizations you can look up online. There's a specificity to them. It's a learning curve to do them right. But change the joint, it changes your motion within minutes rather than trying, like doing a pigeon for, you could do pigeon for the rest of your life and probably get more hip external rotation with the correct mobilization for like 3 minutes.
Doc, awesome stuff, man. I love what you're doing. I love the way that you're thinking and putting some of this stuff out there. Where can people kind of follow up on learning a little bit more? I know you put out a lot of kind of educational things and kind of showing people some of the stuff that we're talking about.
Yeah, probably Instagram's the best, and that's at Dr. ChadRnowlin, or my email, Dr. Chad, DRCHAD at nrgphysio.co. Or text me, 317-707-9966. Happy to chat, happy to communicate, educate, whatever people need. We've recently made the shift to really we partner with corporations to help them minimize their health spending as it relates to musculoskeletal health. And so, like, straight to consumers is not our primary, but we still do have that running in the background. And it's a good opportunity for me just to link up with people, give them a ton of value. We're not really trying to make money over there anymore. So we've got some simple stuff that people can do to test themselves out online. We ran our program online for probably a year with a lot of success, just following our Keystone Reset, L3 protocols, doing coaching online with like OnForm, where we can analyze movement in slow motion, things like that. But I'm happy to chat with anybody.
Yeah, love it. Love it. Doc, we ask all of our guests if somebody's listening to this and they can do one thing to improve their health today, what would that one thing be?
Know your stats. Like learn how to screen yourself.
Good answer.
That's it, because you can't do anything if you don't have a baseline and know what's the truth about what's going on in your body. Test your joints out, know how they compare, know how they affect your movement. If you can at least start there, that can shift your trajectory dramatically. And if we can just create a 1 degree shift for people and help them carry that out for 5, 10, 15 years, their destination is entirely different than if they just continue where they're at today.
Dr. Chad Nowlin, thank you so much, my man. Love the chat.
Been great to be here, Derek.